This session's been called that Kumbhakaran feeling, but I don't think Kumbhakaran had really had sleep apnea. If you see his phenomenology, it's more like Klein-Levin syndrome or maybe hypothalamic obesity. And people have dwelled on that based on the mythological understanding that we have of Kumbhakaran's insatiable um, hunger for food, water, and somnolence. When we think about sleep apnea, we've given it actually to our respiratory colleagues, and we talk about the OSA wheel that is predominantly respiratory. But the way to look at this is that we have this traditional model where in med school we were all taught that sleep apnea is something that occurs in obese individuals, and classically, Mr. Pickwick is often portrayed in the the physical physiognomy that makes us vulnerable to sleep disordered breathing. And the whole thing is deeply rooted in the understanding that you have to snore loudly, be sleepy in the day, have fatigue in the day, have nocturia at night, and sometimes morning headaches. You have a BMI of more than 30 and a crowded oropharynx. But it's much more than that today. And sleep disordered breathing can occur in individuals who don't fulfill these BMI criteria, who may look ordinarily like you and me, and yet can have sleep disordered breathing, and it can have serious repercussions to what it does to the nervous system. And we know about the functions of sleep, and the more we learn, the more we realize how little we know. We know that sleep is vital for memory consolidation. REM sleep is pivotal in maintaining our emotional balance and equilibrium. We know that the autonomic system gets recalibrated and rebooted every night that we are sleeping. We know that our glycemic profile is calibrated at night. And there is a recent last year's paper in by Matthew Walker in Cell Reports, elegantly showing how this is actually demonstrable in human trials. And optimization of body fat storage, the control of blood pressure, immunological competence and upkeep, and most importantly, regulating senescence. So, the biology of senescence, as we know it, is again regulated by sleep and how we breathe in our sleep. And we learned about the glymphatic system in 2013, and we know that there is a brain cleaning system which is exclusively sleep driven. And this glymphatic system is responsible for making sure that the neuronal proteins that are uh, pivotal in cellular function in the daytime don't get accumulated intracellularly or extracellularly. And we've now learned that sleep is vital for optimizing the important cellular autophagy, both lysosomal and mitochondrial, what is known as mitophagy. And we know that these are uh, now strongly implicated in the known neurodegenerative diseases like Alzheimer's disease and Parkinson's disease. And obviously, then, if someone has a neurological disease and has sleep apnea, it is highly likely that sleep apnea will act as a bellow for making that disease worse. So, respiratory physicians who deal with sleep often use this diagram to illustrate that sleep apnea can affect any system in the body. And in the initial years of understanding, neurologists came up and said that, okay, if you have sleep apnea, then what can it do to the brain? And there were morphometric studies demonstrating that strategic loci within the neuraxis could be associated with volumetric neuronal loss in patients who have sleep apnea. But it's actually much more complex than that. And I'll start by showing you a case. This is a female. She's the mother of one of the anesthesiologists I work with. She has forgetfulness. She gets lost in familiar surroundings, but she also has fatigue, lethargy, and loss of motivation. And when I took the story, I was told that she's always been a poor sleeper. She has diabetes, hypertension, and is overweight. And when she underwent a neurological examination, her MMSE was 18 by 30. She was clearly cognitively impaired. When she had the PET scan done, and all of you are used to using PET as a surrogate biomarker for picking up uh, degenerative patterns, and we know that bilateral posterior parietal hypometabolism, as shown here, is very typical of what you see in Alzheimer. And this is the coronal section of her PET scan, and you can see the posterior parietal cutoff, very typical of Alzheimer with that MMSE and the neuropsychological evaluation. So, what's sleep got to do with Alzheimer's disease? We know that putatively, the understanding is that Alzheimer's disease does occur from accumulation of tau intracellularly and amyloid extracellularly with synaptic loss. And this synaptic loss is often driven by microglial activation. Now, all of this process, can it be regulated by sleep? Now, when this patient that I showed you, the mother of our anesthesiologist, look at her sleep study. She had a AHI of 16.9, her supine was 34, and her apnea index was 44.4. And her total REM time was very small, just about 11.8%. So, how many of us worry about sleep staging in patients who have degenerative brain disease? Well, we now have a study. This is a study published in Neurology, the Journal of the Academy. Very small number of cases. This is emerging information. And the understanding now that seems to emerge is that if you have 1% reduction in REM sleep, then there is a 9% increase in the risk of incident dementia. So if our sleep is dysfunctional, then other than the epidemiological data, then even a simple dysfunction in the amount of sleep that we are getting, in the fractionation of sleep, and of course, sleep disordered breathing. And we are aware of Ricardo Osorio's work. He runs a center in New York at NYC. It's called SAM, Sleep, Aging, and Memory. This is data from his work. And they've clearly shown that if you have sleep disordered breathing, it acts as an accelerator for cognitive decline. And patients who have cognitive dysfunction and they have sleep disordered breathing, if you treat their sleep apnea, you can slow things down. New information seems to suggest that REM sleep is an important regulator of autophagy. And therefore, in people like the lady I showed you, if you have sleep disordered breathing and REM loss, it could alter how autophagy works. It can also alter how mitochondria are revitalized when we are sleeping at night. So, almost every tenet of cellular biology that is dysfunctional in Alzheimer is contributed to by in its optimacy requirement by sleep. And we now have information that REM loss is also responsible for activating microglia and producing the so-called M2 phenotype of microglia, where microglia recognize neurons as eat me, and they are responsible for inflammation, phagocytosis, and A beta accumulation. So we learnt about the lymphatic system in 2013, and subsequently it's been portrayed as the garbage truck of the brain, the sleep activated cleaning. We know that it's characterized by unidirectional CSF flow from the arteries to the veins. It abates as soon as we wake up, and supine and lateral postures optimizes it, whereas the prone position decreases its efficiency by 40%. We are also aware that voluntary exercise increases lymphatic efficiency. But more importantly, now we know that sleep apnea can impair lymphatic efficiency. Strokes can do that, so does head injury and diabetes, especially lacunar infarcts. And we have ample biological proof now from studies demonstrating that lymphatic function is responsible for excreting beta amyloid and tau in asymptomatic individuals. And these are studies done in young adults who have no symptoms. Therefore, understanding that if this system in our sleep is vital for regulating amyloid and tau every day in normal people, it has led to the understanding that sleep apnea and Alzheimer's disease have a shared pathophysiological biological cascade. And this shared cascade can result in A beta accumulation intracellularly, extracellularly, and phosphorylated tau inside the neuronal cells. And do we have some surrogate proof for this? This is Melinda Jackson from Melbourne. They looked at patients who came to the sleep clinic for therapy for sleep apnea. And they consented to get a neuropsychology done, and they consented to get a PET scan done for amyloid with the Pittsburgh compound. And those who had severe OSA had a fairly modest elevation of brain amyloid. Therefore, there was a correlation between the two. Similarly, in Iceland, there was a study that was done, again, very thought-provoking. These were patients who were on the database who died from other reasons. But the ones who had sleep apnea had pathology, both neurofibrillary tangles and A beta changes in the brain, very typical of what you see in sleep disordered breathing. Therefore, people in Italy, like Claudio Liguri, who's done a lot of work on this, has written a very thought provoking editorial. Unfortunately, this editorial is published in a thoracic journal. So you and I are not reading it. It's published in the American Journal of Thoracic Medicine. Is it time to consider sleep apnea a risk factor for Alzheimer's disease? And subsequently, many others, including the group from New York, have done large 360 patient studies showing that perhaps in most patients with Alzheimer's disease, in the beginning, there is sleep disordered breathing and then a progressive cascade. So this is the meta-analysis that's been published, and it does seem to imply that in Alzheimer's disease, that is in the beginning, somewhere, it is closely linked to how sleep disordered breathing occurs. So I think it's something to remember. We know that sleep apnea leads to endothelial dysfunction and accelerated atherosclerosis, poses a higher risk for cerebrovascular stroke, augments hypertension, cardiac arrhythmias, impairs lymphatic drainage, and with the frequent nocturnal awakening, the autonomic system becomes unstable. So it can result in cardiac arrhythmias, syncope, and now in ophthalmic literature, AION and retinal venous occlusions, they have a strong correlation with sleep apnea. In fact, the neuro-ophthalmologist with whom I work in Mumbai, every time she sees AION or she sees venous occlusion in the retina, she asks for a sleep study. And of course, it can worsen existing degenerative brain disease. This Wisconsin study clearly showed that if you have sleep apnea, then your risk for stroke is at least 3.5 times, irrespective of diabetes, hypertension, or BMI. And peculiarly, though all of us look at MRI scans with white matter change, we've never worried about what is the relevance of sleep apnea with white matter. And there are some very elegant studies. This is the Korean study showing that sleep apnea is an independent risk factor for white matter disease. And that led to editorials. Unfortunately, most of this data gets published either in sleep journals or in thoracic journals. And so neurologists are not cognizant with it. In fact, there's an Italian study that shows that if you give them sleep CPAP for a period of 12 months, the white matter actually improves. I had the opportunity to look after a young patient. This is my patient. You can see his white matter change. He's 40, he has severe sleep apnea, doesn't have diabetes, doesn't have hypertension. And we have done a repeat scan after a year and a half, and those white matter changes have actually disappeared. So this has also been shown in a study done by Oscar Del Bruto in Ecuador, and this was done in the Inca population who live in reserves in Ecuador, and they looked at them because most of them are obese, they don't exercise, they drink a lot of alcohol, they have hypertension and diabetes. And in their study, if they did a linear regression model analysis, then a person who has sleep apnea has a 4 times higher risk of subcortical vascular origin damage. So I think when you see vascular stroke, especially subcortical dysfunction, think about sleep apnea. We know that sleep apnea produces left atrial appendage remodeling, and it's known to produce atrial arrhythmias. And depending on what kind of remodeling of the appendage that occurs, there's a risk of cardioembolic stroke. So that's another situation. I also didn't know about NPH and sleep apnea until I read about Gustavo Roman's work. So this is Gustavo Roman. In 31 patients who had NPH, who had consecutive patients, 28 of them had moderate or severe sleep apnea when they were evaluated. So I started looking at them, and I have 9 patients now, and all of them have sleep disordered breathing. So this is something that we have not understood, that some patients who have sleep disordered breathing can alter the CSF absorption profile. What is it in the Pacchionian bodies that changes? We don't know. This is the hypothesis put forward by Gustavo Roman in his paper. But what it implies is that recurrent hypoventilation and increased thoracic pressure impedes CSF absorption and can result in NPH. We do know from lots of other work that sleep apnea is associated with seizures of adult onset. And this is Beth Mallow, and there's been lots of other papers by her after that. I have been showing patients in meetings like this where syncope resolves once you treat their sleep apnea. And this has been documented by others too. It's a reflection of how the autonomic system gets recalibrated in our sleep at night. And now we know there is objective studies to show that sleep apnea can promote senescence. That means sleep apnea promotes the biology that makes us look older by telomeric shortening, mediated by sirtuins and also by DNA methylation. So here's something that we need to understand. If you have sleep disordered breathing and you don't get treated, you are more likely to exhibit signs of aging much faster than others. This is not something that I am saying, this is published information. So for us, in what settings should neurologists screen for sleep apnea? I think unexplained syncope, refractoriness in epilepsy, when in adults, especially when despite therapy and compliance, isolated nocturnal seizures in the early morning hours, in the REM period, worry about sleep disorder breathing and hypoxic triggers, unexplained drowsiness in the ICU when metabolics are normal, strokes, especially lacunar and white matter abnormalities, intralobar hemorrhage. So there's a paper about 5-6 years ago done by Julie Greer and the odds ratio for having sleep disordered breathing with lobar hemorrhage is 1.97. So in PH and Alzheimer's disease and in patients with MCI, especially when basic screening for memory evaluation, it appears normal. So I think we are at the cusp of understanding that sleep disordered breathing is not something that should be handled entirely by respiratory physicians. We neurologists need to understand that it could destabilize almost any aspect of physiology that is relevant to brain health. And therefore, it should be a wake up call in a post lunch setting for us to worry about sleep disordered breathing when we see our patients. Thank you. I'm going to stop here.
Thank you, Dr. Desai. I think very comprehensive presentation. I think covering all aspects of neurological manifestation of OSA. And thanks for sticking to time also. I think we'll take questions at the end of all three sessions and then move
Sure.
on to
Thank you
second
so much.
session.
Thank you.